Okay.
Do you want to grow your YouTube channel?
Okay. Yes, I think we're live, Gil. So welcome to the TRT and Hormone Optimization YouTube channel. Welcome to all our viewers and welcome, Gil.
Hey, Steve. Pleasure to be here as always. Thank you so much for having me again.
Hi. So how are you doing there in the United States?
Doing all right. You know, pretty much the same as anywhere else, I assume.
Yeah, crazy world, right? I think we're live, Gil. So welcome to the TRT and Hormone. That's your side, that's echoing.
Yeah, let me see how to mute the YouTube side. And there we go. Okay. So now I can read the questions and we're not going to have feedback noise. So
right. So the goal in this channel, as Gil and I discussed before we went live, is to discuss TRT and hormone optimization. It's not really the goal to discuss steroid cycles for bodybuilding usage, because the first question in the chat box was already about doing a small cycle, but we're not going to answer or give advice on those questions. So I'm sure you understand, since this is the name of the channel. So you already got a compliment on your beard, Gil.
Thank you. It's coming in a little bit, yeah.
Yeah.
Helps to keep me warm in the middle of the summer.
Okay, so we already had some questions under the announcement in the Facebook group yesterday, so I will take some from there to start with. Someone asked, what's the most important thing to look at? Is that free testosterone or total testosterone? And is it okay to dose 300 milligrams a week if that brings my free testosterone to 30? Currently, he is taking 200 milligrams per week with a free testosterone of 20.
Okay. So we generally don't like to chase numbers, as we discuss over and over again. Numbers are pretty much something that helps to ensure that you are not necessarily causing harm to other bodily functions, right? So if we look at metabolic panels, complete blood panels, then we can kind of look somewhat within the ranges and determine, you know, do we have a low state of a specific metric? In the case of red blood cells, let's say in hemoglobin, is this individual anemic, or are they, you know, suffering from polycythemia, erythropoiesis, or erythrocytosis, or anything that is essentially well out of range? When it comes to hormones, it's not a clear-cut answer, because we have several videos discussing the lab ranges of hormones and how they are derived. And we know that this is essentially something that is up for interpretation, and many different labs have different guidelines as well within ranges. For the most part, though, if you're trying to, you know, treat yourself to symptom resolution and you are supposedly not feeling that well with a free T of 20, we have to first understand why this is happening. Perhaps your SHBG is too high, or perhaps your total testosterone is insufficient to have a proper or sufficient free T level. So let me break this question into two parts. The first question was, is it okay to dose TRT at 300 milligrams per week? The short answer is yes, if it's needed. Now, that would be an outlier. We have seen patients medically treated at those doses. It is rare, okay? It is an outlier, it is not the norm, but it can be medical treatment for a particular person for the reason I stated before, if in fact that is what's needed. Now, don't go and just increase your dosage based on your free T number for the sake of saying, well, I want to go from 20 to 30. You need to be able to assess and figure out why it is that your free testosterone is insufficient for you. And there may be other ways to free up more T. So it's not necessarily a matter of dosing at a higher level. It may be more of an adjustment on frequency, diet, lifestyle, or other potential underlying conditions. We know that certain liver diseases or liver toxicity or stressors may elevate SHBG. We know that certain nutritional aspects may elevate SHBG, and that in and of itself is going to lower your free T level. So we need to do a little bit more of an assessment here before we can just give a clear-cut answer and say just go from 2 to 300 milligrams per week. But it's not a complete rule out to say that you may benefit from a higher dose. We just need more information before we can responsibly answer this for an individual.
Yeah. Appa Destiny asked the question twice already. He says, guys, I have a really urgent question. I hope you can help. I'm on TRT Sustanon 250 0.6 every 5 days, but I still suffer from ED and now I am on HCG and Cialis, but still having issues. Can you help?
Erectile dysfunction is a big part of what we treat at my clinic. Unfortunately, it is not something we can help just by saying, here's my testosterone dose, etc. This is a multifaceted approach to diagnosing. It's usually a 30 to 45-minute in-person consultation with the provider. We look at both psychological, we look at history, we look at a trend of how long this has been going on. Erectile dysfunction comes in many forms. It is not pure impotence. It could be a failure to last a sufficient length of time. It could be a insufficient firmness level. It could be performance anxiety induced. There's so many different types of erectile dysfunction and so many different causes. So before we can give a clear-cut answer as to what is going on there, just by looking at the testosterone dose, there's a lot of further assessing that needs to be done with this person. So I'm sorry, I can't really look at your T and just give you a clear-cut answer, but you rest assured that this is something that could be fixed properly, but it does require a heck of a lot more than just a quick question over YouTube.
Yeah. Do you recommend TRT with patients who have muscle wasting due to gastrointestinal disorders like Crohn's disease? I tried to ask my doctor, but he declines.
So we got to figure out, is this muscle wasting disease a form of catabolism that exists from a chemically induced state like chemotherapy or some other medication? Or is this a nutritional imbalance, which is probably more likely for someone with Crohn's or any bowel disease? It's probably an issue of either appetite or absorption or both. So we need to understand, is this individual struggling with protein absorption? Or is this person, in a state of inducing catabolism? We have to assess a little bit more. In general, will TRT prevent or inhibit muscle wasting? To a degree, yes. Okay, any anabolic agent is going to either reverse or minimize the effects of any catabolic condition. There are stronger agents outside of TRT which are more transient, like DHTs. Oxandrolone is one of them. It does a better job at preventing catabolism. It is more anabolic than testosterone. And if this is a transient condition while you're being medicated or treated in a catabolic state, then you can run a course of oxandrolone under provider's care for the sake of preventing muscle wasting. That is what is it indicated for. It is FDA approved specifically for muscle wasting diseases for short periods of time. TRT is more of a lifelong approach. And if you have a chronic disease, which Crohn's tends to be, then it's certainly something you could look at. But again, more metrics need to be investigated, like the age, current, hormone levels, and other health assessments on this individual to make sure he's a candidate for TRT prior to starting something that is presumably going to be a lifelong journey.
Someone asks, what are your thoughts, Gil, on grapefruit seed extract to help lower high hematocrit?
We have a whole video on hematocrit, and we do mention this in there. Look at the upside, okay? The upside is, unless you're taking certain statins or other medications that are contraindicated with grapefruit, and there are some, so you do have to look into that. If it's not contraindicated for you, then there's really no harm in taking it as an over-the-counter supplement you could buy on Amazon or most vitamin shops. The thought of lowering hematocrit, and again, if you watch our hematocrit video, you're going to notice that hematocrit is extremely transient. It changes several times throughout the day, and it is nothing more than a hydration ratio. It is a ratio of hemoglobin or formed elements in the blood, red blood cells, in comparison to your total blood volume. So if you increase the volume of plasma via hydration, you're essentially going to lower your hematocrit. So you always want to look at that first prior to taking any sort of supplemental or medical intervention. And consider that is always going to be your first option. If you increase your aerobic activity level, okay, low intensity, steady state aerobic activity on a regular basis is going to also help with increasing oxygenation and therefore inhibiting erythropoiesis, which is the process of the body producing more red blood cells to compensate for hypoxia. So if you're well-conditioned, your sleep and nutrition is proper, you do not suffer from sleep apnea, you're not a smoker, and you're well hydrated, generally hematocrit's not going to be an issue. So prior to medicating or taking other interventions, even if they're non-pharmacological, make sure that you are approaching every other option from a lifestyle perspective.
Someone, Ryan Greco, just got diagnosed and his only option is Sustanon 250 in his country. The urologist wants me to inject all 250 milligrams every 10 days. Most people split it into 2 doses every 5 days. What do you think?
So I'm not a big fan of Sustanon, and Jordan Grant and I had spoken about this, being that it is a compound that is a combination of 4 different esters, and the time release on it is somewhat questionable and variable depending on the patient. Definitely do not go once every 10 days. You're going to get much more stable levels, and a 250 milligram dose, even though it is short, mid, and long esters, 250 milligram dose is going to have a cascading effect that is generally negative on other hormones, including sex hormone binding globulin. Okay, it's going to have a crushing effect. And over time, as SHBG starts to lower, you're going to start to feel worse. Free T increases, total T decreases, and you're going to start to suffer other side effects. So certainly split it. I would urge you to seek a provider that is a lot more competent in the use of Sustanon and TRT in general. I always tell people, it's great that you're educating yourself. It's great that you're asking questions. You're coming on the channel, you're coming on the Facebook group, and you're becoming smarter. You are your own best advocate for your health, right? But you have to educate yourself. At the same time, you want to make sure that you're under the care and guidance of someone who is competent, because ultimately your provider is not just a script pad. They are there to help when things go sideways. So if you're with a provider that you're not confident in, the fact that you're educating yourself and you happen to know more about your own treatment than he does is worrisome to me. So it's a lot easier to start with a provider who's competent than go a year or 2 or 3 causing damage and then trying to stave off side effects by switching to someone else. Because rather than starting at ground zero and building up together, they're going to be chasing to bring you back to where you were prior to getting you better. And that is a frustrating process, both for the provider and the patient.
Yeah. A very general question, Gil, that we get quite often. And is there any need for other hormones when taking testosterone and pregnenolone? Very general question. How do you answer that?
In general, possibly, maybe, right? We don't know. It really depends on the individual. Again, there are people who will notice a decrease in the upstream hormones. So pregnenolone is one of the upstream. And you also have to look at the HEA, which sometimes is decreased on TRT, and over time, you may benefit from an oral supplementation of about 25 milligrams each morning on the HEA. And you always, got to look at other hormones that are not always sex hormones. You got to look at the thyroid function as well. That can be impacted, and it is dose dependent. We know that anecdotally from guys that run steroid cycles at higher doses, elevated testosterone levels, super physiological levels for extended periods of time are going to have a negative impact on thyroid functions. They do cause hypothyroidism. So we'll notice TSH levels creep up, T4 and T3 creep down, and then over time, people will become dependent on thyroid medications. So take care of your thyroid. Prior to going on thyroid medication, which is so grossly overprescribed, at least in the US, you can look at iodine, sublingual drops. Again, don't overdo it, but iodine is essentially T4. It's the main ingredient for your thyroid to produce T4. And you can look at selenium, 200 micrograms per day, which is also good to sustain thyroid function. So before you go and supplement with exogenous hormones and essentially suppress your glands, try to support them, if you will. So yeah, there are other hormones that we recommend looking at in addition to testosterone. But again, this is case specific and it is not a blanket policy for every patient.
Mm-hmm. About berberine, is there a general or body weight recommended dosage, and does it need to be cycled? Berberine.
Berberine, okay. So berberine is think of it similar to metformin or glucophage, same thing. It is a non-prescription for now, natural herbal supplement that is responsible for regulating blood glucose levels. It does not have a direct effect on lowering blood glucose, such as insulin. However, it does increase insulin receptor sites in muscle tissue, and therefore it will indirectly help to stabilize and possibly lower blood glucose. You do have to be careful with metformin and possibly berberine if you're pre-op. talk to your surgeon if you're going for surgery and discontinue at least 48, 72 hours prior, because you may develop lactic acidosis if you're on this medication. But you generally do not need to cycle berberine if you're taking it for a state of prediabetes or mild type 2 diabetes that is not yet medicated by metformin. You do not want to double up on both medications. So if you find your hemoglobin A1C comes back at, let's say, 5.3, 5.4 or up, once you're at 6.2, 6.3, you should start seeking care from a provider to treat possible type 2 diabetes. But anything between 5.3 and 6.3, berberine can help you in a matter of 6 to 8 weeks to lower your A1C, which is a 90-day rolling average of blood glucose, and essentially reverse the pre-diabetic state. And generally, it's going to be dosed at, and the weight, the question there was regarding weight, it's going to be dosed at either 500, 1,000, or 1,500 milligrams per day. And this dose dependence is going to be based on the individual, their diet, and the level of their A1C when they begin. So it's either once, twice, or 3 times a day, preferably with a meal. So either breakfast and dinner or breakfast, lunch, and dinner, to try not to surpass 1.5 grams per day total on this supplement.
Can I take a pre-workout with L-citrulline and 5 milligrams of tadalafil before workout? Is that a good idea?
Yeah, well, tadalafil is not necessarily going to be pre-workout from a timing perspective. It is a very long half-life, and it's something that is more stable if you take it daily. So you could take it every morning, and it's just going to kind of be built in your system there in a stable level, steady state. You don't need to take it right before the gym. If you were to take, like, let's say, a sildenafil or vardenafil, those are very fast-acting and short to clear. They pack more of a punch, and they're out of your system. So those you're going to time if you're going to use them. If you're going to use tadalafil, in the morning is fine. The L-citrulline, depending on the form, if you're taking it orally, give it about an hour or so before the gym, assuming you have an empty stomach. If you're going to take it in the injectable format, 30 minutes before your workout is fine. Be careful with too much nitric oxide, especially if you're taking any ACE inhibitors, calcium channel blockers, or beta blockers, because risk of hypotension when you increase nitric oxide and vasodilation can lead to dizziness and fatigue, and ultimately can make you pass out. So be very cautious with hypotension symptoms. Don't overdo nitric oxides. Certainly, if you're taking nitroglycerin or anything for heart, consult a provider before you take tadalafil, which is a prescription anyway, or even citrulline, arginine, or any of these aminos that are known to boost nitric oxide. There's something called polypharmacy, which is essentially stacking too many things that have the same or similar mechanism of action together. So to put it in layman's terms, if 1 + 1 + 1 equals 3, that does not mean that taking 3 medications that are independently ones equals 3. Sometimes taking this 1 + 1 + 1 can equal 8, because some medications agonize each other and actually boost the effect. So be very cautious when you're taking multiple nitric oxide boosters at the same time.
Someone asked, does TRT aid the burning of visceral fat? But we recently made a video just on that topic. So please, everyone in the chat box and the viewers, if you have any questions, consider watching the videos we already made to answer those questions extensively. There's a search function in the YouTube channel. There's a search function in the Facebook group. So consider watching those videos first. Someone else said, my doc prescribed 200 milligrams of test, but also Clomid. What do you think about this combination?
We need to know more information. Generally speaking, I mean, again, it's hard to comment without knowing more. This person's age, their reason for TRT. I want to know their doctor's diagnosis of prior to this intervention, what the actual diagnosis was. If they're doing this as a rubber stamp, then I have a lot to say about it. If they're doing this for a particular reason, I'd love to hear the reason. But without knowing the reason, I'll just give you the nuts and bolts of it. Clomid is a SERM. SERMs are selective estrogen receptor modulators. What their job is essentially is to block the estrogen receptor sites. So think of a lock and key, right? So we're putting a key in this lock but this key is not able to turn the lock. So the lock is never activated, but it is occupying the keyhole. So the key that wants to turn the lock cannot enter the lock. So this lock is essentially nullified. That is what Clomid does. Nullifies the estrogen receptor. Therefore, estrogen cannot act on the body. That's not a good thing because we already have a video discussing all the quality benefits of estrogen in both men and women. So now, if we're thinking, why are we going to be on Clomid long-term, right? Because we know TRT is a lifelong treatment, presumably. Hopefully, he doesn't plan on keeping this guy on Clomid for a long time. If he's doing it for fertility purposes for a very short period of time, I can understand it, although I do prefer other approaches, but let's leave it at that. If he's doing this from a TRT standpoint, and he thinks that Clomid is going to increase the guy's luteinizing hormone level for the sake of making endogenous testosterone, as opposed to, let's say, using HCG, which is an LH analog, which will mimic luteinizing hormone, then this is a flawed approach. And I fear, again, I don't want to speculate, but I fear that this is the cause here because I've seen it done many times and it's just incorrect. It is incorrect. And part of the reasons we have this channel and we make these videos is to not just educate the patients, but hopefully educate the providers. Because if we can educate a provider properly and they keep an open mind, non-egotistical, open mind to look at the research, take the data we provide and do their own research and provide their own feedback, and then start to treat patients a little bit better from a more educated standpoint, specifically on hormones, then in essence, instead of educating and helping one patient, we can be helping 1,000 patients by educating his provider. So I urge the providers who may be watching this to take everything we say and research it for yourself and ask the questions. We don't just pull answers here out of a hat. We've done years and years of hands-on hours a day of research on this stuff. We practice what we preach daily, and we've educated many on it. So using Clomid and testosterone together as a form of TRT, for the most part, is a flawed approach.
I know, Gil, we made several videos about when TRT kicks in and so on, but someone asked, when you change your protocol, does it take 4 to 6 weeks to dial in every time?
It depends on the change. It depends on the change. I mean, if your protocol was 200 milligrams once every 14 days, and now you're going to 50 milligrams twice a week, then that is a fairly significant change. You're changing your dose, your frequency, and many other factors will follow. It also depends how long you've been on your previous protocol, because oftentimes a failed protocol, and I'm going to call it a failed protocol because I'm under the assumption that when you change your protocol, it's due for the simple fact that you have not dialed in, or you've gotten a side effect that needs to be mitigated or corrected, right? So if you're changing a protocol and you've been on a particular protocol for, let's say, a year, and that protocol was incorrect and it caused harm elsewhere, let's say crushed SHBG, it may take several months for that to recover. If you've been taking an anastrozole and you just dropped an anastrozole and increased your frequency, and your goal is to recover your estradiol, that may take several months as well. If you're going from 140 milligrams a week split into 3 to 160 milligrams a week split into 3, I mean, a week from now, you're probably going to be pretty much where you want to be. So it really depends on when you say made a change to my protocol. It's a drastic variable here to know what type of change or changes specifically.
Awesome. Is vitamin K2 generally safe to take while on TRT, or will it mess with the blood thickness or clotting?
So it is. So K2 is an antidote for some anticoagulants that are given in a hospital. And it is so effective at essentially reversing the anticoagulative effect that you have to be cautious with it. So it does have contraindications of any blood thinning medication that you're on. So if you suffer from AFib or any heart issue or blood pressure, or if you were put on a prescription of 81 milligrams a day of aspirin, or any other blood thinners, warfarin, heparin, anything, consult a provider before you take K2. For the rest of us, if you're otherwise healthy, well hydrated, in good physical condition, perform regular cardio activity, and you're on TRT, K2 is not going to harm you at a moderate dose, and it is often recommended with vitamin D3 together, as it does aid in the absorption of vitamin D3. So K2 can be beneficial, but it could also be very dangerous if taken by the wrong individual and in the wrong conditions. So my recommendation on K2 is, if you're sure, great. If you're uncertain, even in the slightest, consult your provider and make sure that you don't have any contraindications from a physical or pharmacological perspective where K2 should not be used.
Strong Nerd made a super chat donation. He asks, what are your thoughts on red yeast rice for treating high cholesterol while on TRT? If that's a no-go, on any other OTC you recommend?
Red yeast rice is known to be a natural statin, and it is known to lower LDL and help to possibly preserve HDL. So I am a far greater fan of those with high cholesterol levels who have elevated triglycerides at a fasting state, elevated LDL of, let's say, over 150 or 160, or suffer from low HDL, which is usually more treated non-pharmacologically with niacin. But you can certainly take some red yeast rice, some lecithin, some omega-3 fish oil, and make sure that when you take red yeast rice that you supplement CoQ10, which is often depleted from statin use. So think of red yeast rice as a natural statin, whereas pharmacological statins like simvastatin or Crestor or Lipitor, those things are a lot more harmful. But again, I'm not a big fan of statins, whether they're natural or pharmacological. I'm not a big fan of statins for long-term indefinite use. But if you need it transiently for, let's say, 8 weeks to get your levels under control, it's still something that you want to focus on lifestyle changes rather than being on lifelong statin use. But it does have its place, and it's far less harsh than a pharmacological intervention for statin use. But again, CoQ10 should be coupled with it as well. And it is also over the counter.
Yeah. What are the best ways to reduce physical anxiety, not placebo, he says, from test after first 2 injections 10 days apart? One injection was 150 milligrams, the second 30 milligrams. He had panic attacks after the second shot.
I struggle with the term physical anxiety. Anxiety is psychological. Anxiety is a state of your brain releasing chemicals that cause the physical reaction. But anxiety is generated by your mind. It is not something that your body, it's not subconscious. If you're sleeping, I cannot generate anxiety by doing something to your body. This is a state of mental. Okay, so you have to work on the mental awareness. We have a whole video of TRT and anxiety. You need to identify what it is that's giving you the anxiety. Sometimes I find that the most anxious people when they begin TRT are those that have actually researched it the most. Ironically, those that have actually spent 6 to 12 months reading groups and studying TRT, particularly the wrong groups, or Google, or have spoken to 2 or 3 providers who scare them. They're so terrified of potential risks and side effects, and they are literally going into this shaking. We've had patients in my own office where we teach them how to do their first injection, and they're standing there and they're holding the syringe and their hand is shaking in tremors for 30 minutes. They can't even come close. And it's not so much the needle phobia, sometimes it is, but it's often just the thought of, I'm going to put a hormone in my body. And this is something that, you know, it's got built up sense of both excitement and fear for an extended period of time. And that leads to an anxiety response. So focus on calming techniques, focus on being okay with the process and understanding that it's okay, understanding that you need this. This is, you know, presumably if you're going on it, hopefully you're doing it for the right reasons, you're going to be helping yourself here if it's done correctly. So the anxiety should subside. First of all, low T, we know, increases the rate of anxiety. So you're probably, once you are stabilized in a matter of weeks, you're not going to be as anxious of an individual to begin with for any reason. And secondly, if your levels are too high, then we know that too much free T can cause anxiety due to aggression and shortness of patience. So too low, no good, too high, no good. And anxiety is generally alleviated when you're properly optimized. But there is no physical anxiety. It is something that's induced by the mind.
907 Raven, another super chat. I'm 45. He's on 100 milligram tests sip per week, 5 milligrams tadalafil daily. Still have ED. Will increasing testosterone help?
We answered this about 10 minutes ago. Don't know. Don't know enough. Need to know why he has ED. Need to know what ED means. What does it mean for him? Right? I mean, it's fairly subjective. Any dysfunction at any level from 1 to 100 is a dysfunction to that individual. So we need to know how long this has been going on, what caused it. Are there any traumatic events in his past? Is there performance anxiety involved? Is he a diabetic? Is he hypertensive? Right? I mean, there's so many different, both physical history, lifestyle history, medical history, trending of where he was, how long it's been since he was well. When did this problem begin? Has it progressed? Was it overnight? Right? Was it a sudden drop and then just kind of stayed steady? Was it a slow progression over 10 years? There's so much more to an ED assessment than just saying, here's my dose of testosterone, here's my tadalafil, what do I do? People need to understand this. And unfortunately, I tell patients all the time, they come in with the wrong misconception, going on TRT will fix ED. No, it will not. No, it will not. Possibly if ED was caused by low T over time, it'll prevent it from happening again in the future. It's not going to correct it. Okay. If you drive on a bed of nails and you get a flat tire, your tire is flat. Now, if you drive on a smooth road, your tire is not going to miraculously heal itself. We got to replace that tire. Preventing you from getting another flat means don't drive there anymore. But avoiding that road is not going to fix the flat. It's happened already. So going on T is not going to fix your ED unless ED is directly related to low T currently. So this is a much more involved assessment, much more.
Ken asks how to reduce prolactin without reducing testosterone dose.
Want to know why he wants to reduce prolactin when it was tested? Often guys see prolactin slightly out of range and they think it's a problem. I mean, I don't start to look at prolactin as an issue unless it's like triple range, unless it's like 35 or 40 or 50. Guys come in, oh, my prolactin's at 18, range says 15. Okay. When was the last time, you had, sexual contact? Oh, 3 days ago. Okay. Come back in a week, celibate and let's see. Prolactin always elevates transiently after ejaculation. And it is something that is takes time to come back down. That's essentially part of the refractory period. But you want to rule out prolactinoma. You want to rule out any benign adenomas of the pituitary gland that usually will elevate prolactin significantly, not by a couple of points, but usually you'll see guys come back, 70, 80. That's something that's a direct referral for an MRI or an endocrinologist. But for the most part, you don't really need to worry about prolactin unless you really need to worry about it. Now, if you do need to worry about it, again, I'm not saying go out and get this medication because it is by prescription and it can have issues with cardiac valve function. So be very careful. But Cabergoline or Dostanex is a medication it is a dopamine agonist and it will lower prolactin. Don't run out there and get it because too low of prolactin can have issues as well, as can the direct side effect of the medication. But it is generally how it's treated when it is overly elevated.
Mm-hmm. JL asks, do I need to take the finasteride prescribed by my TRT clinic? Are there TRT clinics prescribing finasteride?
A lot of clinics are prescribing whatever they can sell to make money. It's a shame. Do not take finasteride, please. I presume you're taking it for your hair. Blocking DHT is not only going to negate a tremendous part of the benefit of TRT, it is also going to possibly cause you something called post-finasteride syndrome, which is very difficult to overcome later on, and it's going to make your life miserable. Please do not take finasteride. It is a terrible drug. And avoid it. And quite honestly, if it was prescribed by your TRT clinic, fire them today and find a new clinic. I beg of you. You'll be far better off for it.
Yeah, strange. If people even don't worry about hair loss, why would clinics prescribe that?
Because they read that DHT blockers block or slow down hair loss. And you got to understand, a lot of these clinics are, a la carte. They are basically here to just take your intake fee, take a couple of months up front. And how much medications can we get you on? Can we get this guy to spend $1,000 on pharmacology and call it a day, before he leaves? It's a shame. It really is. I mean, my goal is to try to help people get back to where they want to feel with as little medical intervention as possible, as little as possible. If you need it, you need it. If you don't need it, I'd rather keep you off. I don't want people medicated for no reason. There's just, you know, we don't want to make people dependent on the pharmacy. So we try to give them all of the lifestyle information as we can. Believe me, if there was a way to genuinely take a guy my age, right, mid-40s, and get their testosterone level to an optimal level from a reduced state, from a hypogonadal state, get them back to in a good quality optimal level where they feel phenomenal forever, without the use of exogenous testosterone, we would never prescribe testosterone again. And I'd be perfectly okay with that. Unfortunately, there isn't. But when you look at some of this ancillary stuff that is being prescribed to these guys, I mean, it frustrates me to no end. It's a shame. It's a money grab, is all it is.
Besides using more frequent injections, what can someone with a very low SHBG of 8 to 10 do to improve the SHBG levels?
Understand, frequent injections do not raise SHBG. They merely reduce the amount of inhibition of SHBG production secondary to androgen use. So if you listen to that again, you'll understand what I'm saying. When you inject androgens into your body, you're putting your foot on the neck of SHBG. By injecting smaller doses more frequent, you're removing some of the weight of that foot, okay? You're not elevating SHBG, you're inhibiting it less. To elevate SHBG, watch our SHBG video in the channel. It's about 35 minutes long, where myself and Dr. Grant, and I believe you were moderating that one, Stephen, we discuss specific SHBG, causes of low, causes of high, how to effectively change, if need be, in either direction. And we give you all of the non-pharmacological interventions, including some pharmacological interventions if needed. So that is a lengthy discussion, but we do have a detailed video on it.
Exactly. Stoyan Petkov asks or says, I'm 30, low libido, testosterone is 5.8 nanograms per milliliter, but Ferritin is 0.094 nanograms per milliliter. My SHBG is 52 nanomoles per liter. I start at 100 microgram HCG twice per week, and I feel already great. I don't want to go on TRT because I need to be fertile after 12 months. Any advice? I don't know if you can see the chat, the orange box there.
I see it.
Yeah.
Look, you have to understand something about HCG monotherapy, which is essentially what you're doing. You're taking HCG specifically with nothing else in order to boost testosterone. HCG is a suppressing exogenous luteinizing hormone analog. What this means is that it will shut down your own signal for testosterone production. Now, people are going to say, wait, doesn't HCG help you produce your own testosterone? Yes, in the testicles. But it also shuts off the pituitary. The master switch that tells your testicles to go to work and produce T is being turned off, and HCG comes in and says, stop what you're doing, I got it from here. When you pull that HCG, you're going to be in a state of secondary hypogonadism. What does this mean? Your pituitary is sleeping. You're going to have to do a restart for gonadotropin. So you're going to have to kickstart your pituitary to release luteinizing hormone and follicle stimulating hormone in order for your testosterone levels to resume or stay on track. So HCG monotherapy is a very short-term and flawed approach. You're going to feel better now transiently, and then that's probably going to taper off. So fertility can be maintained on TRT when needed. Usually, there's no guarantees, but you have to kind of make this judgment call. You're only 30 years old, right? You have to make this judgment call. My recommendation to you, it may sound a little unorthodox. So long as you're fertile, go get a semen analysis done, freeze some sperm for now. This way, if anything in the future should happen to change, if you do make a decision to go on T, or if you're unable to regain your fertility in the future, you have some samples frozen and you can still conceive. If you don't need them, you don't need them. It's not that expensive. Go freeze some while you have it. And then make a decision of what's more important in the near future, feeling well and being optimal and being healthy, or worrying about the fertility aspect.
Yeah. Okay. So another question I got per email just before the chat was, someone asked about training. if you're off for a certain amount of time because you're injured like yourself, or you were on holiday lately a few weeks, you couldn't train, what's the best way to start again at the training? Because surely you have lost a lot of mass, a bit of strength, some reps here and there. How do you restart?
You need to ground your head and get the ego out of the way. Don't go in there and hit that deja vu button and say, oh, now I feel at home again, and start back where you left off. Your body is not there. Risk for injury, risk for feeling nauseous, risk for getting dizzy and lightheaded, and risk for severe soreness and muscle tears over the next couple of days is high. Start slow. The good news is you'll get it back fast. Within a matter of probably 2 to 3 weeks, you'll be back at 80%. Not from necessarily an aesthetic standpoint or strength standpoint, but ability to push to where you want to push. Start slow. Make sure you cycle through each body part that you've been training or will be training at least 2 to 3 times. So if you hit a body part once a week, give it 3 weeks. If you hit a body part twice a week, give it 2 weeks or a week and a half. But make sure you cycle through all of your body parts in a very beginner fashion. Stick to more compound movements rather than isolated movements. Stick to things that are more in line with range of motion and alleviate independent joint movement. That means less dumbbells, more Smith machine, right? More cable machines, more things that are going to help you rather than asking your joints that are now in a deconditioned state to help stabilize under loads. And then you're going to minimize the risk for injury. Because remember, going back now and saying, I'm going to hit it hard today because I can, and risking that injury may put you out for another 6 to 12 months. Sacrificing those 2 weeks, you're going to make some progress and you're going to feel a lot better for it. And you're going to lift the train longer. And that's going to lead to long-term progress. So don't hurt yourself. Don't go back in there. Don't make that mistake and get back and say, well, I used to bench 315 for 10. I'm just going to go down to 275. Heck, go to 135. Go nice and slow. Right? Hold isometrics. I promise you'll be sore tomorrow if you've been out for a couple of months. It's literally going back to kindergarten.
Yeah. Great advice. Diesel asked, can I use 0.5 milligrams Cabergoline 1 day before sex for the performance benefit?
I can't consciously sit here and tell people to use medication for performance. As we mentioned before about the prolactin question, Cabergoline is not a free lunch. It does come with some risks, and those risks are cardiac risks. And I can't tell you, yes, do it. Do people do it? Yes. People do a lot of things. Am I going to condone that? I can't. I can't. It's not what it's designed to do. And there's a risk involved.
Yeah. Could someone test his pituitary so he can see how it functions and how much HCG have been suppressed?
How much HCG has been suppressed? Men don't secrete HCG. You can't suppress it. It doesn't exist. It's derived. It's a pregnancy hormone from women. It's derived from the urine of pregnant women and then lyophilized for reconstitution. We don't have HCG in our body. So I think perhaps what he meant was to word it, how much HCG suppresses luteinizing hormone, but I'm not sure exactly what he's asking. So.
Yes. I'm 30 and on 1 cc a week of test SIP. I want to try it twice a week. How would I start the switch? Would I do 1 injection at 1 cc, then go to the half after 3.5 days? How do you switch from one protocol to another, Gil?
You move into that protocol on your next injection. If you're going to use twice a week instead of once a week, split your dose in 2. So if you're taking 1 ml per week, once per week, and you want to go to twice per week, on your next injection, take half of an ml. And then half a week later, take another half of an ml.
Mm-hmm.
It's that simple.
Yeah. Okay, let me have a look. I had some other questions at hand here. Do you have a preference in most cases for test SIP or test enanthate with your clients, Gil? I know they are almost exactly the same. Any pros and cons for both? Sesame oil versus cottonseed oil preference. That was in the Facebook group.
So we use testosterone cypionate with 98% of our patients. It's readily available in the United States. It's cost effective. It's medically effective. And we're very familiar from experience with its mechanism in the body. The pharmacokinetics of the medication and how it affects our patients is something that's very familiar to us. So that's what we use. As far as the carrier oil, we use grapeseed oil because that is the most commonly used carrier in compounded testosterone cypionate. Cottonseed oil is generally used in Testosterone Depot, which is a cypionate brand name like Watson or Depot Testosterone. Those are generally made with cottonseed. And we only will switch a patient on a carrier oil if they have a direct allergic reaction to the carrier oil. Now understand, allergic reaction doesn't mean anxiety, because people always call and say, I think I'm allergic to this one. Can I try that one? How do you know? My heart was racing and I started sweating. No, that's not an allergic reaction. If you have a direct allergic reaction at the injection site, redness, itching, swelling, welts that won't go away in a week. Okay, things that are like obvious allergies to a carrier oil, I could count on one hand how many patients we've had to switch to the carrier oil. So grapeseed oil tends to work for most, and it's really a non-issue.
Yeah. How to reduce iron levels without donating blood? He writes, zinc, calcium, vitamin C, and other diet changes haven't helped.
Question is, why does he want to reduce iron levels? I mean, I don't know if he feels that they're too high, and or if this is just secondary to possible erythrocytosis. So again, I don't know what he's really train of thought is here. But if you truly have elevated iron levels, avoid iron intake, eat less red meat. Obviously, don't supplement iron. If your iron's elevated, then this is something that would have been diagnosed in a lab by a provider, and they would have probably taken the appropriate intervention. But I don't recall seeing very many people with iron levels that were concerning. Mm-hmm. So I'm not sure why he would want to lower it. And if you're on TRT, then generally ferritin is reduced on TRT just as an uptake factor from erythropoiesis. So you'll notice guys on T have slightly lower iron and ferritin levels than guys who are not.
Diesel asks, what was the free testosterone range used to be before it was lowered to 240?
240 what? Free testosterone?
Yeah. The ranges were higher. They used to be higher.
240 what? The range, at least here, and it varies by lab, of free testosterone in nanograms per deciliter is between like 8 to 15 on most labs, not 240. So I'm not sure exactly what unit he's using. But we're not concerned with ranges. You got to understand, labs can change ranges every other year if they want. Human biology and evolution takes millions of years. Okay, millions of years. It is not something that is, in 2016 this was normal, and in 2021 this is normal. It's not how we operate as human beings. It's not how our anatomy adapts. So the labs can literally flip numbers as they want. It's mostly political and financial.
Oh yeah, the question I already had in the Facebook group as well from Bennett Cohen. Has there been an increase in the number of younger men who seem to need TRT?
He's a nice guy, Dr. Cohen. I like him. He's a pretty active member of the group, and I've had some chats with him. So thanks for asking. Yes, unfortunately, we have seen the age of the patient demographic that comes into the clinic seeking help drop. Now, you can look at it in a two-faceted approach. First, you could say the attention given to testosterone as a result of social media and groups like ours, combined with the popularity of fitness, bodybuilding, and aesthetics as a result of social media like Instagram, has spiced up significantly the interest of younger and younger crowds to go out and seek performance enhancement. So that is a one-faceted approach to look at why younger people are now seeking treatment. I try to not count those metrics and not just say, are younger people coming in? Because again, they could be coming in for the wrong reasons. I like to say, are younger people actually getting treatment because they need it? And that's the unfortunate part. The answer there is, again, yes. So what we're noticing is that there is a decline in hormone levels in men who are younger and younger and younger. And this is a continuing trend. I attribute this to a more toxic environment in the form of inferior nutrition, inferior and sedentary lifestyle habits as a result of technological advances. When I was a kid, Steve, you and I are probably a year or two apart. We're both mid-40s. When we were kids, you come home from school, you drop your books, and you're outside until it's either dark or your mom grabs you by the hair and drags you in. You're playing ball, you're riding your bike, you're picking fights, you're doing what kids do. You're out of the house and you're active. And I look at my kids today and they're glued to their iPads and their laptops and their phones and their TikTok and all these other things. So if you look at the way people are living their life today, sitting in a chair, this is primarily the result. It's a lifestyle and dietary approach, and you got to also consider the fact that, as I sit here right now, there's probably 15 or 20 Wi-Fi and Bluetooth networks going in and out of my brain. This didn't exist 25 years ago. This will impact your pituitary function, your thyroid function. This is radiation at low doses, chronically and constantly. Okay, so we can't escape the world, but we do need to adapt. And unfortunately, you're going to continue to see younger and younger generations as it becomes more mainstream seeking treatment. It pains me to see, but it's a fact. So it's a good question, and I'm glad that we addressed it, because I think that when the whole medical community starts to wake up to this fact, things are going to probably start getting a little bit better in the form of testosterone treatment. Right now, it's still looked at as a taboo, but the necessity is growing, and it's unfortunate, but it's there.
Yeah. Justin Co asks, how do you get ferritin up without causing iron overload?
I don't worry about ferritin too much, so long as there's no diagnosed anemia or borderline anemia. So one of the things that I look at on CBC primarily is RBCs, hemoglobin, and MCV. So MCV is the mean corpuscular value, and this is a factor that determines the size of your red blood cells. And why is this important? Because there are several types of anemia that is often found in older patients who are deficient in testosterone, because we already know that testosterone increases the uptake of iron and generates erythropoietin out of the kidneys to increase red blood cell production. And guys who are lower T, and we find this in guys in their 50s and 60s with low T levels, are borderline anemic, and they're always tired, they're always cold, they're gasping for air when they go up a flight of stairs, and they're suffering from cognition issues as a result of hypoxia secondary to hemoglobin levels declining. So why is it important to diagnose the reason for low hemoglobin? Is because you have, I'm going to touch on the three types of anemia, because the fourth one would be aplastic, which is induced by chemotherapy, or bone marrow deficiency, which is more rare. But the more common ones is we have anemia called microcytic, we have normocytic, and we have megablastic. The megablastic anemia, also known as macrocytic, is where your MCV value is high. It's above range. It's, let's say, over 100. And what that does is it tells me that you're either deficient in folic acid or vitamin B12. So giving this guy iron to fix his anemia is moot, and you're just going to overload him in iron, cause constipation, other side effect, and you're going to maintain his anemia. But when your MCV is low, let's say under 80, which is the bottom end of the range, now we know this is an iron deficient anemia. Okay, and normocytic is where your MCV is normal, but you're still anemic. And this can be an indication that perhaps you have colorectal bleeding, or you have some sort of internal bleeding, or you have a kidney problem where erythropoietin is not being secreted. So when we look at the differential portion of your CBC, which is why it's important to get a full CBC done, it helps us to diagnose not just what is this disease, but what is the cause of this disease. And then you can plan an intervention more efficiently. So before you run out and say, how do I increase my iron? again, it needs to be assessed better by someone who truly understands this condition.
Yeah. Okay, we're getting till the end of the live stream, Gil, almost an hour. Maybe one more. What's the best time to take Gonadorelin?
Never. Never. There's no reason to take Gonadorelin. Take HCG. Okay. You should take HCG. Gonadorelin is a float approach. It can help only in cases of tertiary hypogonadism, which are extremely rare. It acts to replace the hypothalamic function, and it goes under the assumption that your pituitary function and testicular function are still sufficient. And in most men with low T, one or the other or both usually have failed. So Gonadorelin is as good as taking water for the most part. It's a waste of money. And the reason clinics are prescribing it is many of them no longer have access to HCG because they're just not using the correct pharmacies. So they tell you, well, Gonadorelin is as good or better because that's what they have, and they still want to make money on this product. We don't prescribe Gonadorelin. We don't recommend it for the reasons I just stated. And we do have a video that is specifically titled HCG versus Gonadorelin, and we go into the details as to why and how each one works.
Right. There's a lot of things we don't recommend, Gil, like finasteride, aromatase inhibitors, Gonadorelin. Yeah, you don't have to take everything others recommend. So, right. So thank you so much, Gil, for answering all these questions during an hour live with the viewers. And thank you everyone for watching. And anything else you want to leave these guys with, Gil?
It's always a pleasure, and I'm really, really happy that we get to do these videos, and I'm really happy that guys show up with these questions because it's important to get this information out there. And I'm just passionate about educating people. I literally have no bias here. Yes, I'm in the testosterone business. You'll notice that my background here is not my clinic; it is my nutrition company. And if people reach out to me through my website, nextleveldietetics.com, if in fact they are a candidate for TRT and they wish to be treated and they are in the United States, yes, I'll direct them to my clinic. But this is not about self-promotion. Otherwise, you'd see my clinic name behind me. This is about educating patients so that they can go into their providers with the correct questions. Not so much so that they understand how to treat in place of a provider, but so that they understand if their provider is lacking the proper knowledge to manage their care over the long term. And if that's the fact, then they have two options. They can see if their provider is open-minded to educating themselves. And if they're not, seek another provider. Do not become someone's guinea pig and do not be a rubber stamp for anybody. Okay. Again, you're your only advocate that's going to really care about your health. So educate yourself, and hopefully the providers are going to get some of these, videos and start educating themselves as well. I've gotten a ton of messages over the years from providers saying, "Hey, I've watched these videos. Thank you. I now practice differently, and my patients are better off for it." And this isn't about a pat on the back. This is literally about every time I see that, I know that we've helped hundreds of people.
Exactly. I appreciate a lot, Gil, you doing this for everyone in the chat box. And thank you everyone in the chat box for leaving your message. So give this video a thumbs up, and I'll close it here.